My name is Chris Woolslayer. I'm the Manager of Training for Access Matters. People will probably continue to connect on the web and over the phone for the next few minutes, but since we have a lot of material to cover, we'll go ahead and get started. A few brief housekeeping items. If you're having trouble with the webinar software, please know that it is being recorded and will be made available online in about a week. If you can connect to the webinar and the audio portion but get kicked off at any time, just reconnect using the instructions provided in the email that was sent to you. You should have received an email this morning containing a copy of the presentation, a sign-in sheet, an evaluation form, and a fax cover sheet. We ask that everyone sign the sign-in sheet and complete the evaluation. I included the fax cover sheet just to make this process a little easier for you. After the webinar, I will be compiling a list of those who attended for reporting purposes. Since background noise is a big problem on webinars, we have everyone, all of the listeners muted. If you do have a question, please type it into the chat box on the right side of your screen. And then at the end of the webinar, I will read the questions to our speaker and she will address them. So I am honored to introduce our speaker for today. Her name is Denise Walsh. Ms. Walsh is a certified professional coder and has been working in the healthcare industry for over 20 years. As a consultant, her responsibilities range from assisting clients in the creation and implementation of compliance plans, designing and implementing charge capture and coding systems that maximize reimbursements, and reviewing accounts receivable processes to strengthen revenue capture. She has implemented and provides consulting support in the review and implementation of EMR systems and HIPAA privacy and security compliance plans for our physician practices. She has extensive experience and has assisted in the credentialing and payer contracting for new and established physicians and practices. She currently works with SHR Associates, but prior to this, Ms. Walsh served in the capacity of billing coordinator and practice administrator for several specialty practices. Ms. Walsh received her BS degree in Allied Medicine from The Ohio State University and is a member of the American Academy of Professional Coders. So with that, I'm going to now hand it over to Denise. Thank you.
Thank you very much, Chris. I appreciate the introduction. As Chris said, my name is Denise Walsh. I'm with SHR Associates. SHR Associates has been in business since 1981, and we are here to help physicians, hospitals, and healthcare organizations navigate through the ever-changing world of the healthcare environment. During today's presentation, we are hoping that you will be able to learn the differences between ICD-9 and ICD-10, outline the impact that ICD-10 will have on your practice, be able to create an action plan for your practice's transition to ICD-10, explain the importance of accurate and appropriate coding and documentation that will accurately support the ICD-10, and we will also review different types of patient information that must now be documented to support ICD-10 codes. And then we will discuss some frequent encounters that you might see as a practice and how to appropriately code them for ICD-10. As most of you know, ICD-10 implementation will begin October 1st, 2015. Time's running out. It's less than 4 months away, and as we look now, there probably will not be any more delays. There is a possibility that there might be a transition period for ICD-10, but it is very doubtful that there will be another of your practice. The whole point of changing to ICD-10 will improve clinical communication. It will let us capture data about signs, symptoms, risk factors, and comorbidities to better describe clinical issues overall. It will also enable the U.S. to exchange information across country borders. Other countries across the world have been using ICD-10 for years. We are now just getting onto the bandwagon for this transition. Ultimately, better data paves the way for enhanced quality and greater effectiveness of patient care and safety. The benefits of ICD-10 will impact everything from patient care to the practice's financial bottom line. So what are the differences between ICD-10 and ICD-9? ICD-10 has a greater code set, a much larger code set. Diagnosis codes currently in ICD-9 are about 14,000. We will increase that to almost 70,000 diagnosis codes with ICD-10. Procedure codes will increase from 4,000 to 87,000. So what are the differences? There are 7 main differences between ICD-9 and ICD-10. First is laterality. ICD-10 increases the codes by specifying laterality, especially in regards to areas of injury and neoplasm. In fact, simply specifying right, left, and bilateral will address 40% of the increase in codes within ICD-10. One of the second differences is a placeholder. ICD-10 codes do not have placeholder characteristics. ICD-10 will use an X placeholder for certain codes to allow for future expansion of that diagnosis. There's also the overall number of codes that we just discussed that will increase with ICD-10. We are going to almost 70,000 diagnosis codes. However, your clinic will only use a subset of that subset of those codes. You currently don't use all 14,000 of the ICD-9 codes, so you will not use all 70,000 of the ICD-10 codes. It will just be a new subset of codes for your specialty. Another difference is severity. ICD-9 has limited severity parameters. In contrast, ICD-10 will expand those severity parameters: acute, subacute, chronic, recurrent. These are all terms that will be used more frequently in ICD-10. ICD-10 has a number of combination codes to better capture the complexity of the patient's condition. In ICD-9, there is only one type of an exclusion note that is listed in the reference manual. ICD-10 will now have 2 types of exclusion notes to give you more instructions on how to properly use and not to use a diagnosis code. And lastly, the difference is the number of characters. Currently, ICD-9 uses a 3 to 5 character code. This is a numeric code, and now ICD-10 will use a 3 to 7 character code, which will now become alphanumeric. The characters will be able to support flexibility and expandability for the patient's diagnosis. The similarities between ICD-10 and ICD-9 are the reference book. The reference book is set up very similarly to ICD-9. It has a tabular index, and the book is set up pretty similarly. It has a chronological list of codes that are divided into chapters, and the chapters are based on body systems or conditions. The chapters are set up very similarly to ICD-9 with a few exceptions. There have been a few reorganized chapters and a little reconstruction of some of the chapters, but basically set up the same way. So you will be able to navigate through the reference manual as easily as you did for ICD-10. ICD-10 book also has an index set up exactly the same way as ICD-9. There will be an alphabetical list of terms. You will also have an index of diseases and injuries, an index of internal causes, external causes, a table of neoplasms, and a table of drugs and chemicals. The reference manual will also contain many of the conventions that the ICD-9 book has, such as code first, use additional codes, use manifestation codes, only use this code when or if. So all of those guidelines will still be in place when using the ICD-10 manual. So why is it necessary for us to convert to ICD-10? ICD-9 diagnosis codes are divided into chapters based on body systems. During the years of maintaining and expanding these codes within the chapters, the more complex body systems have run out of codes. The lack of codes within the proper chapters have resulted in new codes, and those codes have been put in and rearranged in a very confusing order, and it makes it very difficult to find some of the correct and appropriate specific codes that you were looking for. Another driver in replacing ICD-9 is the increased specificity of ICD-10. The belief is that the more specific data will provide better information for identifying diagnosis trends, public health needs, epidemic outbreaks, and even bioterrorism events. Other important changes to note with ICD-10: injuries are now grouped by anatomical site rather than by injury. So an example of this would be, although it's not specialty specific to this webinar, but would be ankle sprain. Now, if you were looking up a diagnosis for ankle sprain, you would look up under sprain strain and go to the body part that was injured. In ICD-10, you will now just look up the body part rather than the injury and look for the complication. V codes, which are status codes, and E codes, which are external codes that are currently used in ICD-10, will be incorporated into the main classification rather than separated into supplementary classifications as they are within ICD-9. ICD-10 has new definitions. In some instances, new code definitions are provided reflecting modern medical practices. These new definitions are not appropriate or do not reflect every specialty, but for some of the specialties, they are there, and we will go through that as we go into this webinar a little bit more. There has also been some reconstructing and reorganization of some of the chapters within ICD-10 to help more easily find the diagnosis that you are looking for. So the code structure for ICD-10 will now consist of alphanumeric characters and will be 3 to 7 digits long. The first 3 characters are the code base. Digits 4 through 6 provide greater detail: etiology, anatomical site, and severity. A code using only the first 3 digits is to be used only if there is no further subdivision. If further subdivision is required and not in the code, it will be considered an invalid code. The 7th character is only used in certain diagnoses under certain chapters and is to provide data about the characteristic of that encounter. And we will get into the 7th digit here in a second. So to give you an example of a current code that you might use quite often, abdominal pain. Currently in ICD-9, that code is 789.00 to 789.09. As you can see how that code will now break out in ICD-10. This will show more specificity as well as severity in the code combination. This is another example of how a diagnosis now in ICD-9 will break out for ICD-10. So why is it important to prepare for ICD-10? Knowing what ICD-10 is, how it's evolved, and the main differences between ICD-9 and ICD-10 are a great start. However, realizing that there are benefits to your practice can also put this transition process into perspective. There are 4 areas that we're going to focus on to help you prepare for this transition. Clinical, operational, professional, and financial. How each one of these will affect your practice. So the benefits of ICD-10 clinically. Clinically, it will allow for both easier research on patients' medical history and for increased public health reporting and long-term tracking of illnesses. It will enable patient segmentation of care, improve protocols, and provide new insights into clinical care. Ultimately, the use of ICD-10 will result in more accurate and complete clinical decisions that are based upon improved data collection and evaluation. Operationally, ICD-10 supports practice transition to risk-sharing models with more precise data and for patients and population. ICD-10 also enhances the definition of patients' conditions, providing improved matching of professional resources and care teams to meet the patient's specific needs. It also affords for more targeted capital investments to meet the practice needs through better specific patient conditions. Professionally, ICD-10 provides clear, objective data for credentialing, privileges, and quality reporting. ICD-10 improves reporting and aids in the prevention and detection of healthcare fraud and abuse. In addition, it provides more specific data to support physician advocacy of health and public health policies. Financially, this is the bottom line to your practice. ICD-10 will also improve data for peer comparisons and utilization benchmarks, as well as better documentation for patient complexity and level of care. ICD-10 will enable practices to capture coding for new technology and may also reduce the risk of audit exposure by encouraging the use of diagnosis codes with greater specificity as supported by clinical documentation. So the timeline is near. The implementation of ICD-10 requires significant change to clinical and administrative systems that capture and report diagnosis codes. Time's running out. October 1st is less than 4 months away. Are you prepared? Is your practice prepared? What do you need to do to get your practice ready? The first thing you need to do is create a plan. So your plan should consist of assessing the impact of ICD-10 to your practice. Identify the team and all the players that are involved in the transition. Engage your vendors. Prepare a budget and forecast. Arrange for training and education of all staff. And test your systems and processes. Identify the current systems and work processes that use ICD-9. The implementation of ICD-10 affects more than just your administrative transactions. Understanding the current systems which use ICD-10 will help to direct you in the processes and systems that will need to be updated for ICD-10. ICD-10 will impact every aspect of your practice: patient access, medical management, information systems, and financial services. So how do you assess the impact? Well, a completion of an assessment is critically important because without the impact assessment, an organization cannot reasonably predict the length of time or the amount of resources required for the implementation preparation to go live for ICD-10, and therefore can't plan an accurate timeline or budget for the work involved. So how do you assess the impact? Run utilization reports. This will identify your most frequently used diagnosis codes. This could be 25 to 50 of the top codes that you use in your practice. Run a separate report that will pull patients with those diagnoses. Use this list to randomly pull charts and begin a documentation audit. Utilize the GEM system or any other mapping system that you may be using to crosswalk your ICD-9 codes to an ICD-10 code selection. Compare your current documentation to see if your documentation is sufficient enough to assign the appropriate ICD-10 code. This will give you a good idea of where you need to start. Does your documentation need to be improved? What do you need to do going forward? If your documentation currently does not support ICD-10 codes, then you need to start working on that. Train your physicians. See what aspects are missing. And then you need to revisit this. Have a process in place that you will revisit this on a regular basis until your documentation meets the required specificity. How does the workflow, how will your workflow change with the ICD-10 transition? Look at the areas that you currently now use ICD-10. These areas that will need to be considered with your new processes. Any of your clinical documentation, anywhere within your practice that you are clinically documenting, not just the medical record, but on any other forms, anything that goes out to any other offices, anywhere you are clinically documenting on for patient information will be involved. Any patient encounter forms or super bills will need to be revised. Your quality reporting will need to be reassessed, as well as your public health reporting. Another part of your plan should be to contact vendors. This is a part of your assessment that will affect your provider's contracts. It's important for you to understand your payer's payment schedules and to bill using the appropriate ICD-10 codes. Because of the increased specificity of ICD-10 codes, payers may modify the terms of their contracts for billing. Payers may require you to report the code with the highest specificity. They may alter their payment schedules and reimburse differently for higher versus less specific codes. So make sure you know the details of your contract and any changes that may result as to the transition for ICD-10. Contact your provider reps. Have a one-on-one conversation with them and get the details. Identify your key players. Create an implementation team. Get your physicians involved as part of the ICD-10 implementation. It will help you if you have a physician, a leading physician, champion the cause for ICD-10. So are your vendors ready for ICD-10? Well, as part of your plan, you need to engage get specifics on how they intend to transition smoothly to ICD-10. Your EHR and practice management system vendors are the most important vendors in this transition. How do you know that they are ready for the ICD-10 update? Well, you need to know the right questions to ask and get details. Ask them, what is their ICD-10 solution? When will their ICD-10 functionality be available? Are they using tables or mapping solutions for the ICD-10 system? How will their ICD-10 solution affect the workflow? This is very important. There may be a lot of changes in the process to not only your documentation, but to the whole billing and claims process. So see how it will change your workflow. How long will it take to make a code from the super bill for ICD-10 as it took for ICD-9? What is the time element? Are there a lot more lot more steps involved? What are the differences? And how will your system prevent an invalid code from occurring? Will it give you clinically accurate ICD-10 codes? Budgeting for this transition is one of the most overlooked items of an action plan. You will need to budget for time and costs related to this transition. You need to account for the cost associated with technology upgrades, training, testing, compensating for decreased productivity, and support implementation activities. Include expenses for system changes, resource materials, and training, as well as possibly legal and consulting fees. Training is one of the most important steps of your transition plan. It is critical to ensure that your staff is knowledgeable about ICD-10 code sets and preparing them for the use of these new codes. There is a wide variety of training opportunities and materials available through professional associations, online courses, webinars, and online training. You need to assess your training needs. Each staff member within your organization may require different training based on their involvement with ICD codes. Providers will need intense ICD-10 training. Identify staff who have already been exposed to the structural differences between ICD-9 and 10, the nuances of mapping and terminology basics. They may need less training. Tailor a more robust training for staff who are more involved in your coding and documentation process. Determine the type and the source of training each of your practice staff members need based on these guidelines. Well, documentation training is going to be needed for all of your clinicians. Anyone who documents in the patient's medical record. This includes physicians, nurse practitioners, physician's assistants, and any nursing staff who, again, document within the medical record. Coding training for staff members who work with codes on a regular basis. And overview training for staff members who engage in clerical functions. Your coding staff will require a significant amount of training to learn how to use the new code set and correctly capture the use of ICD-10. Providers may also receive training specific to their specialty. There are 4 categories of training. There's refresher, awareness, clinical documentation, and coding. Again, you will need to assess what type of training each of your staff members will need. Everyone learns differently, so to determine the method will be most beneficial to you in your practice. There are traditional classroom teaching, audio conferences, webinars, online classes, self-directed learning programs. All of these are acceptable and appropriate depending upon your staff and their learning needs and requirements. Refresher training. This is medical terminology as well as physiology and keys to understanding the use of ICD-10 coding. Refresher training is very necessary for some specialties to be more focused. Awareness training is an overview of ICD-10. This type of training is beneficial for your entire staff. Clinical documentation training should be geared, as I said, to your physicians, your nurse practitioners, physician's assistants, and other staff who document within the patient medical records. And then coding training. Coding training is designed for coders and billers, but most prepared practices will insist that their clinicians have some coding training as well. Clinicians should not rely on others or systems to do their coding. It is also a good idea to supplement your training with technology. There are many ICD-10 practice and training apps available. ICD Pulse and Stat ICD-10 are examples of two good ICD-10 apps. The last element of your action plan is testing. Your trading partners, which are your payers and your clearinghouses, are the organizations with which you exchange various transactions. Conduct test transactions using ICD-10 codes with your payers and clearinghouse. Testing is crucial. You will need to test claims containing ICD-10 codes to make sure they are being successfully transmitted and received by your payers and billing services or clearinghouses. Check to see when they begin their testing process and the test dates that they have scheduled. Again, this step is crucial. Every aspect of a patient visit is involved in the coding of the patient encounter. Thus, every aspect of the visit will then be involved in ICD-10 coding. Why is clinical documentation important? To have complete and accurate documentation supports medical necessity. Medical necessity is the principal criteria for payment. It will support proper payment and reduce denials. Complete and accurate documentation ensures accurate measures of quality and efficiency. It ensures accountability and transparency. It captures the appropriate level of risk and severity. It supports clinical research, enhances communication between health providers, and most importantly, complete and accurate documentation promotes quality health care. So there are new parameters, new concepts of severity and risk that need to be documented to support ICD-10 documentation, ICD-10 codes. They are comorbidity, manifestation, etiology or causation, complication, detailed and anatomical location, sequela, lateralization or localization, biological and chemical agents, degree of functional impairment, lymph node involvement, and procedure or implant related. So how do we do this? How do we put these standards, these parameters into our documentation? It's fairly easy. We need to go back to the basics. Providers will need to go back to what they learned in school regarding their documentation. They are taught these things to document: type of condition, onset, etiology and cause, anatomical location, laterality, severity, environmental factors, time parameters, comorbidity or complications, manifestations, healing levels, findings and symptoms, external causes, and type of encounter. All of those things are easy to document and typically should be documented now. We just need to get to the point where we are no longer complacent and we are adding those fine details to our documentation to make sure that our documentation will now support an ICD-10 code. There are three main categories of documentation change within ICD-10. There's definition changes, terminology changes, and increased specificity. And the increased specificity itself lends to more than a third of the expansion of new codes. This is right, left, and bilateral. So here's an example of definition change. Definition changes do not occur within each specialty or each chapter of ICD-10. But for this example, I used trimester. The definition of trimester for ICD-10 purposes is now calculated from the first date of the last menstrual period and is documented in weeks. The first trimester is less than 14 weeks and 0 days. Second trimester is 14 weeks, 0 days through 27 weeks, 6 days. And the third trimester is 28 weeks through delivery. This new definition change now more closely corresponds with the clinical definition of trimester. And you can see with the example of ICD-10 codes that are listed that the 6th digit will now reflect the trimester of the patient. An example of terminology differences. There is a term they are now using within ICD-10 called underdosing. This is an important new concept, and it allows the clinician to identify a patient who is taking less medication than is prescribed. So when documenting, you can document the underdosing and the reasons for which the patient is underdosing. Is it intentional, unintentional? Are they just being non-compliant? And then what is the reason? Is it a financial issue? Is it a hardship? Is it a language barrier or an age-related disability? So this term has now been added as a diagnosis to your diagnoses in ICD-10. With increased specificity, as we said before, increased specificity is now adding a localization. We have right, left, and an example of this would be abdominal pain and tenderness. We now have specific codes for right lower, right upper, left lower, left upper, abdominal pain, quadrant pain, as well as periumbilical pain. Another example of increased specificity is the intent of encounter. When documenting intent of encounter, you will need to include the type of encounter and the complications related to that encounter. This is an example of the tabular list for ICD-10. As you can see, it's set up, as I said before, pretty similarly to ICD-9. It lists all of the chapters. They are all alpha chapters. Every chapter is there except for X. And it has a list of codes within each of those chapters. This slide shows the varying code changes within each chapter. For example, you can see the pregnancy-related codes will increase from 1,104 codes to 2,155 codes. That's just an example of the differences between the code sets from ICD-9 to ICD-10. This is a list of common codes, ICD-9 codes, derived from some of the STD clinics that I've recently worked with. This current list will show you the current ICD-9 code and the crosswalk over to ICD-10. And this is just a few of the codes that I ran into. But again, you should run reports, specific reports for your practice to determine what are the top codes being used and do those crosswalks yourself. This will give you a good idea going forward the specificity levels that you will need to get to the ICD-10 documentation. So poor specified coding is defined as coding that does not fully define important parameters of the patient's condition that could otherwise be defined given information available to the clinician or the coder. So should we or should we not use unspecified codes? Well, specified codes should be reported when there are supported information available in the medical record and the clinical knowledge of the patient's health condition. If a definite diagnosis has not been established by the end of the encounter, it is appropriate to report signs and symptoms in lieu of a definite diagnosis. When sufficient clinical information is not known or available about a particular health condition to assign a more specific code. Coding should comply with payer guidelines for use of unspecified codes. Unspecified codes have been removed from ICD-10 whenever a clinician should be able to identify a more specific code based on clinical assessment. A perfect example of this is the code for cutaneous abscess of the hand. Well, there are only two codes. It is right and left, and there should be no reason that there is not clinical documentation to lead you to that specificity. It's either right or left, one or the other. So hopefully the documentation will have the specificity needed. Now there is a place for unspecified codes, and sometimes these codes do make sense. The patient may be early in the course of an evaluation. The claim may be coming from a provider who is not directly diagnosing the patient's condition. The clinician seeing the patient may be more of a generalist and not able to define the condition at the level of the expected specialist. And if there is insufficient information to make a more accurately defined diagnosis. So there is a place for these unspecified codes. The place is just limited. Using unspecified codes too often or inappropriately will definitely send up red flags to the payers. So I'd like to take a little time now and go over some clinical scenarios. These are actual encounters that I have seen within some of the local health departments, and we've just kind of redeveloped them to see how they would now be diagnosed with using ICD-10 codes. So let me go over the first example with you. And the first example is probable HSV-2. The reason for the visit is symptomatic STD screening. This is a 39-year-old female, presents complaining of soreness of the labia, moderately painful. Symptoms began yesterday, associated with odor and burning sensation. Uncomfortable to wear underwear. Partner notified her yesterday that he had another sexual partner. A detailed GYN exam performed, including testing for HIV, Hep C, syphilis, and HSV. Examination findings are urethra and ulcerization of the EFG. Positive WIS test and clue cells. So the assessment would be an STI screening and probable HSV-2 perineal ulceration and BV. Now, if you were coding this in ICD-10, we would use diagnosis code Z11.3. This is encounter for screening for infections with a predominantly sexual mode of transmission. We would use N76.6, ulceration of vulva, and N76.0, acute vaginitis. So hopefully you can see the differences in ICD-9 to ICD-10 and some of the information necessary to get to these codes. Go to another scenario. Scenario 2, chlamydia. 22-year-old patient presents asymptomatic, states contact to chlamydia. Contact was genital. Last contact 3 days ago. Physical exam, skin, inguinal nodes, male genitalia within normal limits. Testing includes syphilis screening, chlamydia, Our third clinical scenario is a follow-up for counseling visit for depression and contraception. 23-year-old female is sexually active without contraception. 5 partners within the last 2 years. 2 partners within the last 2 months. Past partners are positive for drug use, marijuana, and pills. Patient found out that friend had chlamydia and patient had sex with friend's partner. Patient considers pregnancy and resisting to contraception. 1 occurrence of suicidal thoughts. Taking Prozac daily without improvement. Discuss test results from prior HSV-1 positive. Patient states she has never had a cold sore. No tears today compared to last visit. Reviewed all contraception options. Patient declined. However, did pick up condoms in the restroom. Urged patient to return for Pap test and given Prozac. Assessment would be contraception management and depression. And for this, we would code first the encounter, the Z code Z30.09, encounter for general counseling and advice on contraception. Z72.51, high risk heterosexual behavior. And then we would use F32.9, major depressive disorder, single episode unspecified. Now, depending upon how the documentation stated, we may possibly be able to use other diagnoses that are listed here. Major depressive disorder, recurrent, recurrent mild, moderate, or severe without psychotic features. So depending upon the episode and the documentation, it will determine how we will code this depression. So our last clinical scenario is bacterial vaginosis. And the chief complaint is vaginal discharge with odor for 1 week. The 28-year-old female is an established patient. Presents complaining of a thin grayish white vaginal discharge with a notable smell accompanied by vulvar itching. She first noted symptoms about a week and a half ago. Patient states she tried to self-treat using over-the-counter yeast preparations approximately 1 week ago without relief of symptoms. She denies any history of similar symptoms in the past. Last menstrual period was 2 weeks ago, normal cycle. Last PAP 8 months ago, normal, no previous mammograms. Her social history, physically active. She is in a new monogamous relationship with male partner for 5 weeks, sexually active with protection, denies history of STIs, and admits to frequent douching and bubble baths. Immunizations, not immunized for HPV. And then on exam, we have vitals, examination of pelvis. We did labs within the office and immunizations, again, not immunized for HPV. The assessment and plan states bacterial vaginosis, prescribed 7 days of, well, I'm not really good at pronouncing prescriptions, so bear with me, metronidazole. I apologize again for my pronunciation. Discussed with an administrative HPV vaccine in the office today. Provided vaginal hygiene pamphlets and instructed patient to avoid douching and using bubble bath products and to refrain from intercourse. So, N76.0, acute vaginitis, N76.1, subacute and chronic vaginitis, N76.2, which is acute vulvatitis, and N76.3, subacute and chronic vulvatitis. There is no indication of previous episodes or ongoing care for acute vaginitis is selected. Bacterial vaginosis is not usually associated with soreness, itching, or irritation. Therefore, it is coded separately. And ICD-9 includes a variety of vaccination codes, while ICD-10 offers only one generic immunization code. So this is how we would code this encounter. For for the ICD-9 code, the 616.10, the vaginitis, we would crosswalk that over to N76.0, acute vaginitis. We would also code the vulvar pruritus at L29.2, and the encounter for immunizations for the HPV vaccine at Z23. So it is important to stress clinical documentation and how it relates to good patient care. Clinical documentation is not just about coding, and coding is not just about payments. Accurate coding is a requirement for good health care. Good health care data is critical to improving the quality of care and the effectiveness of care and ensuring patient safety. Complete and accurate documentation of important clinical concepts of the patient condition is requirement for good patient care. The requirements for documentation to support ICD-10 are consistent with documentation to support good patient care and improve healthcare data. This is a team effort. As we move towards the transition to ICD-10, everyone needs to get involved, from your clinicians to your coding staff to administration. Everyone has a role, and to successfully move to a successful transition of ICD-10, everyone needs to get involved. There are a ton of training resources out there for you. The AAPC, the American Academy of Professional Coders, is a great resource. It has a lot of training information, has crosswalks for mapping from ICD-9. CMS is phenomenal. It's the best resource out there. CMS, the Road to 10, not only gives you a whole plan and gives you a timeline for what needs to be done, when and how. It also gives you videos that are specialty specific to help you with your documentation process, as well as giving you crosswalks and mapping. You also have the AMA, and you also have the American Health Information Management Association. All of these are wonderful resources, as well as a lot of the major payers. Care First, United Healthcare, they all have sites on their websites with ICD-10 information regarding the transition, how they will, what they're doing during this transition process, and they also have good mapping tools associated with the transition as well. So if you have any questions, that's the end of our presentation. I hope you found it useful. And if there
Hi, it's Chris. Let me see. We do have one question. It is, I am a biller for behavioral health. Our providers use the H codes. Will this change in the ICD-10?
So they are using the H diagnosis codes now. I'm not. Are they using H codes, H as in their, I'm not really sure I'm understanding the H codes. I don't deal a lot in behavioral health, but I can tell you that I will find out that information. Their CPT codes will not change at all, and if the H codes are the, if that is their chapter with ICD-10, they will not be changing. But I will get specific information. I do not know that off the top of my head, but I will be able to get that information and get back to you.
Okay.
Are there any other questions?
He says thank you. No, that's the only question I see. Okay, well, that was great. If anything else comes through after we close out the webinar, I'll be sure to pass it on and get the information back out to everyone. So I just want to thank everyone for joining us today and thank Denise for her wonderful presentation. Please remember to complete your evaluation, your sign-in sheet, and fax those materials to me at your earliest convenience. Thank you again, and enjoy the rest of your day.